The broadcast is now starting. All attendees are in listen-only mode.
So welcome to the CADASIL Connection webinar series. I am Bert Kosiski from Minneapolis, Minnesota, representing cureCADASIL Association and a family with CADASIL. I will be moderating today's webinar along with Jane Gunther, the president of cureCADASIL. And the audience will be muted during the presentation, but at any time you can post questions in the drop-down questions pane, and we will try to answer them at the end of the talk. cureCADASIL is a nonprofit organization dedicated to helping patients, families, caregivers, and other supporters touched by CADASIL. We aim to unite patients and the medical community toward the common goal of treatments and ultimately a cure for this rare genetic disease by promoting communication, advocacy, research, and education. So it is my pleasure today to introduce Dr. Julie Rutten from the Leiden University in the Netherlands. And she works with the Dutch CADASIL Research Group. The head of that is Saskia Lesnick-Oberstein. Her research interests have been NOTCH3 mutation position and how it affects the CADASIL phenotype. And also she's worked on preclinical development of NOTCH3 cysteine correction. But it's really the NOTCH3 mutation position and effects on phenotypes that she's going to focus on today. Currently, there are no treatments that can delay or cure CADASIL, but in 1996, a gene mutation was discovered that causes CADASIL. Dr. Rutten and her co-workers discovered that mutations causing CADASIL can occur in different segments of the gene, producing a protein important for the function of arteries supplying blood to the brain. There are 34 segments in this gene, and a mutation in any one of these 34 segments can lead to abnormal NOTCH3 protein causing CADASIL. However, not all 34 have the same frequency or propensity for causing disease. Understanding the mutations that cause CADASIL is an important first step for going on the road toward treatment. So without further ado, I think I'll try to switch here to Dr. Rutten.
Okay, thank you, Bert. Is my screen visible now?
Yes, I can see it.
Okay, perfect. All right, well, good morning to everyone listening in the United States. Good afternoon here to people listening in from Europe. And thanks again for the invitation to do this webinar today. So I was asked for this webinar a few months ago, and then the cureCADASIL organization asked me for a provisional title. And the first thing which came into my mind is the question which has been keeping me busy in the last couple of years. And that question is, why do certain individuals with a NOTCH3 mutation get CADASIL and others do not? So let me first admit I do not have the definite answer to this question, but I can share with you our research results and the progress we have made in this context. So in very short, what I will discuss today is how we discovered that the NOTCH3 mutations that cause CADASIL are actually not rare, but have a very high frequency in the general population. That these mutations do not only cause CADASIL, but are associated with a much broader disease spectrum. That we identified an important modifier of NOTCH3 disease severity, which is the position of the NOTCH3 mutation. And finally, I will discuss the relevance of these findings for CADASIL patients and discuss our future plans. So before going into the content, I want to give you a little bit of a background about our center and our research group. I work at the Leiden University Medical Center. So Leiden is a town situated close by the sea in the Netherlands, just south of Amsterdam. And our hospital is the National Referral Center for CADASIL patients and their family members. So CADASIL patients from all over the Netherlands are referred to our multidisciplinary CADASIL outpatient clinic. We also have a NOTCH3 diagnostic lab, meaning that DNA diagnostics from individuals from all over the Netherlands is being performed in our lab. And we have a translational research group where we do natural history studies and biobanking, and also a preclinical therapy development using in vitro and in vivo models. So these are at this moment, the core members of our research team. So our group is founded, and the PI is Saskia Lesnick-Oberstein. She's been working on CADASIL for more than 20 years. I've been working together with her for 10 years now. Guido Graafstein is one of our postdocs working on therapy development and biomarkers. Mark Villa-Cuenca is our postdoc in the lab at the moment, working on vessel-on-chip models. And Remco and Minne are our PhD students who are performing the clinical studies. So it's mostly the work of these guys that I will be presenting today, so you will see their faces popping up on the screens more frequently. Regarding the therapy development, Saskia Lesnick gave a webinar about this in 2018. So if you want to learn more about it, I would recommend to have a look at this webinar. The update I can give about this today is that we are still working on this therapy, and that we are now also collaborating with a biotech company. So this company has committed to invest both time, resources, and money into the further preclinical development, which is of course great news. It also means that I cannot disclose any details about the progress at this point. So I hope that we will be able to do that in the near future. So back to the topic of this webinar, which is about cysteine altering NOTCH3 mutations and how we completely changed our perspective on these mutations, where we initially thought they were simply the cause of the rare early onset cerebral small vessel disease CADASIL. But we now see that much more frequently they should be considered a risk factor for small vessel disease in the general aging population. So starting with CADASIL and how we classically view it. So it's a mid-adult onset stroke and dementia syndrome, where patients suffer from recurrent ischemic strokes and vascular dementia, and also often migraine with aura, psychiatric disturbances, and apathy. It has an autosomal dominant inheritance and is caused by very characteristic cysteine altering NOTCH3 mutations. So all CADASIL patients have such a typical cysteine altering NOTCH3 mutation. The fact that the disease severity is variable has long been recognized. So even within families, for example, the age at onset of stroke can vary. However, until recently, we thought that the disease was completely penetrant, meaning that every individual with a cysteine altering NOTCH3 mutation at some point in life develops the CADASIL phenotype. And this image shows a brain MRI scan of a classical CADASIL patient, where all the white here is our hyperintense lesions in the white matter, and these arrows indicate the lacunar infarcts. This is a very oversimplistic cartoon of CADASIL pathophysiology. So it always starts with a cysteine altering NOTCH3 mutation. And this mutation leads to an uneven number of cysteine residues in the NOTCH3 protein. That causes protein multimerization and aggregation. And this NOTCH3 aggregation takes place in the vessel wall. This causes damage to the vessel wall, resulting in a disturbed cerebral blood flow and ultimately the clinical symptoms of stroke and dementia. In 2015, I was doing a study on CADASIL prevalence in the Netherlands. So this map shows the number of patients we had at that time in the Netherlands with all kinds of different NOTCH3 mutations, which we had a very clear view of because all the DNA diagnostics was being done in our lab. So we simply counted the number of individuals diagnosed with such a characteristic NOTCH3 mutation, from which we extrapolated estimated minimal prevalence of 1 in 30,000 individuals, which was quite similar to what had been found before, but we also immediately realized this must be an underestimation of the true prevalence. Because what we saw in the time that we were doing CADASIL diagnostics is that the number of CADASIL families that we identified was continuing to increase. So we started in 1998 with only 5 families. In 2015, we already had more than 200, and this number just kept on increasing. Also, we saw that for most families, we only had one patient with a molecular diagnosis. So only one individual per family where the NOTCH3 mutation was detected in our lab. And of course, if there's one individual, there must be many more around. But for some reason, they did not, at least not get a molecular CADASIL diagnosis. So up until then, all prevalence estimations of CADASIL were made based on patients that had clinical symptoms. So were referred to a neurologist for some CADASIL, so for some symptoms such as stroke and dementia and a positive family history. So we thought, well, what if we take a look at it from a different angles, naming starting from the NOTCH3 mutations themselves. So not the clinical symptoms, but just the genetic defect. And that was possible at that time because of the GenoMed browser. So this was something novel, starting at around 2015, where within GenoMed, all kind of exome and genome sequencing data was collected from various disease and control cohorts from all over the world and made publicly available for anyone who wants to have a look at any specific research question. So more than 140,000 unrelated individuals were included in GenoMed, and there was only DNA data available. So no phenotypic data, only the DNA sequence and the information about their ethnicity. So this tool is really easy to use. You simply type in NOTCH3 in the browser, you get all genetic variants that are found in these 140,000 individuals. And here we specifically focused on the mutations that can cause CADASIL, which are always located in a specific part of the protein. So maybe I should explain this a bit. This is a cartoon showing the NOTCH3 protein. And the extracellular part is where you find the NOTCH3 mutations causing CADASIL. This extracellular part is composed of 34 EGFR domains, so repetitive domains. And the mutations causing CADASIL always lead to a cysteine amino acid change in one of these 34 EGFR domains. So these were the mutations that we selected from GenoMed. Based on CADASIL prevalence estimations, we expected to get approximately 5 cysteine-altering NOTCH3 mutations. So what we found was 450, so almost 100 times higher. And this number corresponds to a population frequency of 1 in 300 individuals worldwide. If we then zoom in on the various ethnicities represented in GenoMed, we saw that the mutation frequency was the highest in Asians, where approximately 1% of individuals has a NOTCH3 mutation, but also in individuals from a different ethnicity, the frequency was much higher than what you would expect based on the CADASIL prevalence estimates. And if we would extrapolate this to the US population, my expectation would be that there are approximately 500,000 individuals in the US with such a typical cysteine-altering NOTCH3 mutation. So apparently, the patients we diagnose with CADASIL in the clinic, they represent only 1% of the whole population of individuals with a cysteine-altering NOTCH3 mutation. And then the question is, what's going on with the other 99%? Are we missing all these CADASIL diagnoses? Are these mutations present in these individuals but not causing any problems? In other words, are they non-penetrant? Or could they be associated with a milder, later onset phenotype, which is not recognized as being caused by a NOTCH3 mutation? So as I said, this we could not address in GenoMed because there was no phenotypic data, but luckily a few years later, other biobanks became available, which did allow us to analyze this. So we did actually 2 parallel studies using 2 biobanks that link exome and clinical information. One study was done by our PhD student, Remco Hak. He went to the United States to look into the Geisinger Discover cohort. This is a hospital-based cohort, including over 90,000 individuals, which for some reason were referred to a hospital in the United States. They had a very wide age range with a mean age of 57 years, and a subset had a brain MRI on indication, so only if there was some sort of suspicion of neurological disease. At the same time, I did a similar study using UK Biobank. So this is a population-based biobank in the United Kingdom, which includes 500,000 individuals. And by now, all these individuals have had exome sequencing, but at that time in 2019, the first 50,000 exomes were released. So these were the ones we used for our study. All UK Biobank participants are older than 49 years with a mean age of 64, and a subset has had a brain MRI, which is random, so irrespective of the presence or absence of clinical symptoms. The analysis we did in both these biobanks always started with identification of our, what we termed the case group. So those are the individuals with a cysteine-altering NOTCH3 missense mutation. We then selected a control group, which was age and sex matched, and we did a medical chart review focusing on neurological symptoms associated with CADASIL, such as stroke, TIA, dementia, depression, and migraine with aura. We also scored the vascular risk factors, and if there was a brain MRI available, we analyzed small vessel disease markers, including the white matter hyperintensities, which we scored according to the VISICA scale. So this is a scale going from 0 to 3, where 0 means no white matter hyperintensities at all, and 3 means extensive white matter hyperintensities. And we also counted the number of lesions. So starting with the results Remco obtained in Discover, he identified 119 individuals with a cysteine-altering NOTCH3 mutation. This corresponds to a frequency of 1 in 685. This is a table showing the clinical symptoms which he scored in his cases and controls. And what he found was that cases had a higher stroke frequency compared to controls. So 12.7% of cases had had a stroke compared to 4.9% of controls. All the other clinical symptoms that are normally associated with CADASIL were not more frequent in cases than in controls. Also, if we then compare this to what we normally see in a typical CADASIL population, we saw that the phenotype was indeed much milder in this database. So here you can see that in a CADASIL cohort of a similar age, we would expect almost half of individuals to have had a stroke, and also an increased frequency of other CADASIL associated symptoms. So this is something we completely did not see in Discover. There were 29 individuals with a NOTCH3 mutation of whom a brain MRI was available. And looking at the white matter hyperintensity, so the VISICA scale, what we saw was that there was a trend towards higher white matter hyperintensity lesion load in cases compared to controls. So overall, this did not reach statistical significance, although we did clearly see that VISICA 3, so the highest score for white matter hyperintensity lesion load, was more frequent, was more frequent in cases than in controls. On the other hand, also almost 1/3 of cases had a VISICA score of 1, and here a VISICA score of 0, and also 1/3 a VISICA score of 1. So again, also lots of individuals with a very mild brain MRI. Similar results for the lesion counts. Again, we saw a trend towards higher lesion counts in cases compared to controls, but also again, a lot of cases, in this case 70%, did not have any lesions at all on the brain MRI. Then moving to UK Biobank, here we identified 108 individuals with a NOTCH3 mutation, so that's a frequency of 1 in 450. The results on brain MRI regarding the white matter hyperintensities were quite similar to what we saw in the Geisinger Discover Biobank. So more cases more frequently had a VISICA score of 3, and also more frequently a VISICA score of 2. When we looked at stroke in UKB, we found that hardly anyone with a NOTCH3 mutation had had a stroke. So this is a Kaplan-Meier plot showing the percentage of individuals free of stroke, and this purple flat line, almost flat line, means that almost no one in UK Biobank had had a clinical stroke. And this is the line which we see in CADASIL patients, where after age 70, almost everyone has experienced a clinical stroke. This is an example of the type of brain MRIs we encountered. So the most severe individual we saw in UK Biobank was this 52-year-old with already extensive white matter hyperintensities, also the tunes. But we could also see individuals aged 50 years with absolutely no abnormalities on the brain MRI. And this is something we up until then had never seen in individuals with a NOTCH3 mutation, because the classical CADASIL, again, is shown on the right-hand side. That was the image we were used to when looking at someone, the brain MRI of someone with a NOTCH3 mutation. So this is all, of course, in population databases. There it can be very mild. And then we thought, well, but can this then also occur in individuals who come from a diagnosed CADASIL pedigree? So individuals who have close relatives, which also have been diagnosed with a NOTCH3 mutation. So here for this, Remco looked in our CADASIL registry, and he looked for mild NOTCH3 cases for which he used the criterion that they should not have any stroke or dementia, and their brain MRI after age 50 should have no or only minimal abnormalities. And he did find quite a number of them. So these are 7 different individuals from our CADASIL registry, and you can see their brain MRIs, and I think you can see that they only have very minimal white matter hyperintensities, if any, and none of them had lecunes. So apparently, even within CADASIL pedigrees, and some of these individuals even had a first-degree relative with a classical CADASIL phenotype, even then it can be so mild. So this shows that CADASIL, as we classically know it, represents only the very severe end of the NOTCH3 associated small vessel disease spectrum. And these mutations apparently much more frequently cause a milder small vessel disease, which occurs at a later age. And in some individuals, these mutations do not cause any signs of small vessel disease at all. And then the question, of course, is how is it possible that a NOTCH3 mutation in one individual manifests as such a severe phenotype, whereas in the other does not seem to cause any problems? Well, one important determinant we have identified, and that is the effect of NOTCH3 variant's position. So as I mentioned, the mutations in CADASIL can be found anywhere in the 34 EGFR domains of the NOTCH3 proteins. However, in CADASIL patients, what you see is that most individuals, approximately 2/3, depending on which cohort you look into, have a mutation in one of the first 6 EGFR domains, and only 1/3 has a mutation in EGFR domain 7 to 34. In GenoMed, in Geisinger, in UK Biobank, in all these population biobanks, it's completely different. Here we identify only a few mutations in the first 6 EGFR domains, and the vast majority are found in EGFR domains 7 to 34. Given the fact that we know that the phenotype is so mild in these population databases, this led to the hypothesis that EGFR domain 1 to 6 mutations are more severe than EGFR 7 to 34 mutations. And this is something we tested in our own CADASIL cohorts. So these are all diagnosed CADASIL patients, but even in this relatively severe population, we saw that the ones with an EGFR domain 7 to 34 mutation had a later onset of stroke than the ones with an EGFR domain 1 to 6 mutation. And this was approximately 12 years difference. We also looked at brain MRI abnormalities using a European CADASIL cohort. And also here we found that the 7 to 34 mutations had a lower white matter hyperintensity volume than the EGFR domain 1 to 6 mutations. So this is something we are now investigating further in a prospective setting. So Remco and Minna are working on what we call the DIVINAS study. This is an acronym for disease variability in NOTCH3 associated small vessel disease. So a prospective study including 97 individuals with an EGFR 1 to 6 mutation and 103 individuals with an EGFR 7 to 34 mutation. Our study protocol includes a one-day visit to the Leiden University Medical Center where we obtain medical history. We do a brain MRI, a psychological test battery. We take blood and skin biopsies for biobanking. And we did the baseline study in 2019-2020. And now 2 years later, Minne is doing a 2-year follow-up of this cohort, which includes the exact same protocol, but now also including a collection of cerebrospinal fluids and imaging of the retinal vessel, with the purpose of maybe at some point finding a good biomarker which can be used in future clinical trials. The data analysis of DVNOS is still ongoing. I can share some preliminary results with you, which is that we were able to confirm the difference between EGFR 1 to 6 and 7 to 34 mutations. So the age at onset of stroke is different between the two groups, and also the EGFR 7 to 34 patients have a lower survival than the EGFR 1 to 6 individuals. Then the next question, of course, is why do 1 to 6 mutations cause a more severe phenotype than 7 to 34 mutations? And one of the hypotheses we had was that maybe there are differences in NOTCH3 aggregation propensity. So this is what we analyzed. Could there be differences in NOTCH3 aggregation between EGFR 1 to 6 and EGFR 7 to 34 NOTCH3 mutant proteins? And this was a study performed by Guido Gravestein, our postdoc. He selected a subset of individuals from our DVNOS study with EGFR 1 to 6 and EGFR 7 to 34 mutations. And then he made 2 subgroups with a severe and a mild phenotype. And so it's important to realize that although overall EGFR 1 to 6 is more severe than EGFR 7 to 34, there is of course overlap in the spectra. So some EGFR 1 to 6 patients can have a mild phenotype, and we also know 7 to 34 patients with a severe phenotype. So there is overlap here. Guido looked at the skin biopsies of these individuals and has set up a method to quantify the NOTCH3 aggregation load. So he did a staining with the NOTCH3 antibody, and if you do that in a CADASIL patient, you get this brown staining of the vessel wall, which is abnormal because healthy individuals do not show any NOTCH3 staining. So he then subtracted the vessel area from this NOTCH3 ECD positive area, resulting in the NOTCH3 score. Oh, sorry, he divided the NOTCH3 positive area by the vessel area, resulting in the NOTCH3 score as a measure for NOTCH3 aggregation load. He also did this ultrastructural analysis using electron microscopy, because what you then can see in CADASIL patients are these deposits of granular osmophilic material, also called GOM, as indicated here by the arrows. He found a striking difference in NOTCH3 aggregation loads between EGFR 1 to 6 and 7 to 34 patients. So this is an example of the type of staining you would typically see in EGFR 1 to 6 patients compared to a 7 to 34 patients, which is clearly much less. And if you take a look at this graph, so the individual dots are the individual patients. And as you can see, there are approximately 6 EGFR 7 to 34 patients who do not show any NOTCH3 staining at all, whereas this was found in all EGFR 1 to 6 patients. For GOM, we saw a similar result, more GOM in the EGFR 1 to 6 patients compared to EGFR 7 to 34, and again, quite a number of EGFR 7 to 34 patients with no GOM at all in their skin biopsy. So these are, of course, analysis in skin, and the actual disease manifests in brain. So the next question was then, well, is this representative for what's going on in the brain vasculature? So the patient numbers, of course, are less for this analysis because we can only do this in post-mortem material. But fortunately, we do have access to some post-mortem material. And what we found there was indeed that also in brain vasculature, the EGFR 1 to 6 individuals have higher NOTCH3 aggregation loads than in 7 to 34. So the findings in skin seem to correlate with what we observe in brain. The correlation with disease severity was not as clear. So here again, the NOTCH3 score, and here are the GOM. So for the EGFR 1 to 6, we did observe a trend towards lower NOTCH3 scores in those with a mild phenotype compared to severe, similar for EGFR domain 7 to 34, but this did not reach statistical significance in this relatively small sample. For GOM count, we did not see any difference between severe and mild for EGFR 1 to 6, and we did observe a trend for EGFR 7 to 34. So this is something we are going to look into further. But clearly, what is shown from this data is that the NOTCH3 aggregation is higher for EGFR 1 to 6 mutant proteins than EGFR 7 to 34 mutant proteins. So probably this is one of the molecular mechanisms that play a role in the differences in disease severity that we see in these patients. And to further study this correlation, we are now going to analyze our full DVNOS cohort of 200 individuals. And this is work that Minne is doing in the next couple of months. Then we have another interesting model which we want to use to further understand the molecular mechanisms underlying the differences between these various mutant proteins. So we know that they aggregate more, but then the question is, why do they aggregate more and what else is going on? So for this, our postdoc Mark Villa-Cuenca has set up a nice, what we call vessel-on-chip model. And this is a model which is based on inducible pluripotent stem cells, which we derived from CADASIL patients with both mild and severe mutations. He has set up protocols to differentiate these inducible pluripotent stem cells into the relevant cell types that are present in the vessel wall, so the endothelial cells and the vascular smooth muscle cells. And he then co-cultures them into a fibrin hydrogel. And if you do that long enough, then these cells form some sort of vascular structure in vitro. And that is shown also here by this video that Mark made. So in purple, you can see the endothelial cells are lining the vessel wall. And in green are the vascular smooth muscle cells. And if you keep these cells together in culture, what you can see is that more and more cells are lining the vessel wall. So this is a model we are going to look into in the next years, hopefully, to better understand the molecular mechanisms. So this already brings me to my summary, where I've shown you that NOTCH3 cysteine altering mutations are not only the cause of CADASIL, but also cause a mild later onset small vessel disease, and in some individuals even no small vessel disease at all. And that we identified NOTCH3 mutation position as the most important disease modifier known to date, where we can conclude that if someone has an EGFR 1 to 6 mutation, they almost always get a CADASIL phenotype. This can still be variable, so the age at onset can vary, but almost everyone at some point in life develops CADASIL clinical symptoms. For EGFR 7 to 34, this is completely different. These variants only rarely cause CADASIL and much more often cause a mild later onset small vessel disease. And at least one of the mechanisms playing a role here are the differences in NOTCH3 aggregation propensity between these mutant proteins. However, of course, there's more to this story. NOTCH3 mutation position is not everything. There must be other modifiers because, for example, what we now encounter in our studies are individuals with the exact same NOTCH3 mutation, but a huge difference in disease severity. So to the left-hand side, you can see a 50-year-old a male with an EGFR domain 17 mutation with severe CADASIL phenotype on brain MRI. And next to it is an individual, also male, same mutation, similar age, but hardly any abnormalities on brain MRI. So here, the NOTCH3 mutation position cannot be it because it's the same mutation. And then the question is, what's going on here? Are there environmental factors playing a role, or maybe are there other genetic modifiers? I think one of the concrete goals or aims we have with this research is that we want to improve the individualized disease prediction for individuals in whom a NOTCH3 mutation is found. And this can be either in a CADASIL familial setting, so knowing you're at risk and then having a genetic test, but it can also be in individuals in whom such NOTCH3 mutation is found as a chance finding during routine whole exome sequencing for some sort of other disorder. And what we want to do is when someone is young, when they are diagnosed with a NOTCH3 mutation, we want to be able to predict better what is their chance of getting CADASIL, and if they get CADASIL, at what age can they expect their first clinical symptoms. Knowing which patients are at risk for severe disease is also important in view of possible future clinical trials, where we ideally first would want to select those patients at risk for early onset severe disease, because these are the patients that would benefit most from a potential therapeutic strategy. And finally, in a more longer time frame, I think understanding the genetics causing this disease variability is also important for understanding pathophysiology and may lead to the identification of novel therapeutic targets for CADASIL patients. So finally, our future plans. So they are focused, at least my plans are focused on further understanding this NOTCH3 disease variability. We now have what you could call a rather simplistic idea of its EGFR 1 to 6 versus 7 to 34, but there might be effects of specific mutations, which is something we want to look into. We are going to do a study looking at other genetic modifiers which may explain the extreme intrafamilial variability that we see in our patients. And finally, using our vessel-on-chip model, we hope to further unravel the molecular mechanisms. So with that, I would like to thank our research team of whom I presented the data today, our LUMC collaborators, international collaborators, funding agencies, and also would like to mention the Dutch-Belgian patient organization. So this is like the little Dutch-Belgian sister of cureCADASIL. It's an organization we are in very close contact with, and our discussion with this organization are really a great inspiration for our research. Thank you for your attention, and I think I will give it back to Bert now, who I believe will moderate any questions you may have. Thank you.
Yeah, Julie, thank you very much. This is a really great summary of a lot of work that has gone into all this, and very, very interesting. Let's see here. So I encourage people to type in questions in the question box. There is one question right now, and that is, what is the prospect for gene therapy? CRISPR.
Yeah. Yeah, I mean, so CRISPR is of we in theory could also apply for CADASIL. So until now we have been working on mRNA targeting therapies, but in theory you could also do a DNA targeting therapy. It is something we are still looking into. It's also something which I think is still in very early days. So if it at some point becomes available in the clinic, this will take a lot of time, but it's certainly extremely promising technique which might at some point also benefit CADASIL patients.
So are there other populations or other databases that you could confirm or validate your findings, you know, with regard to the EGFR number and the phenotypes?
Yeah.
I mean, would it be the same, you know, same thing in Asia or in Africa? And of course, we have African Americans, the United States, and or is it, you know, more unique to the European population?
Well, I think these kind of databases, so with both exome and clinical information, they are popping up everywhere now. So I know from the United States, for example, there's the Million Veterinaries program, which I think is still ongoing, but at some point could be a very interesting resource to look at from specifically for the US population. We are very interested in the Asians, especially because they have such a high NOTCH3 mutation frequency, so 1% of the individuals there. So yeah, we would be very keen once these databases, which I expect will become publicly available in the near future, we will certainly be looking into those as well.
Yeah, in the United States, the Million Veterans Study is up and available, and it's a pretty good size, although they don't have complete data in all of the samples. The other big project is called the All of Us study, and their goal is 1 million people, and they have complete genetic and clinical backgrounds. It's very well funded, but they're only about halfway there, I think. So, but eventually that will be another good database to do a FIWA study.
Yeah, the challenge is we need always not only the exomes, but ideally not only clinical information, but also the brain MRIs. Now that we know it's so mild, the brain MRIs are really crucial to get a good idea about the phenotype.
Do you have any, in your database, do you have any other clues for moderators, like cardiovascular risk, cigarette smoking, things like that? Does that modulate the phenotype?
Yeah, I mean, so the cardiovascular risk factors, this has also been found previously by researchers from the UK that this plays a role, and also by a German research group. So this is something we are definitely also looking into in our DFINA study to more or less weigh the relative role. So how big is the influence of smoking and of hypertension, the ones that have been described earlier, and how big is then the effect of the NOTCH3 mutation position. So we'll definitely include that in our analysis.
Thank you very much for moderating, and Julie, for your great presentation. This is Jane Gunther, and I just wanted to bring your attention, Bert, to several more questions that came in. If you click to open up the question box, they're easier to see. And one is, do you think a clearance of these NOTCH3 protein aggregates, for example, with the antibody therapy, is a promising research avenue, especially since we've seen that NOTCH3 knockout mice are viable? I definitely think that antibody therapy targeting NOTCH3 aggregates could be a promising strategy. So the NOTCH3 aggregations really seems to play a central role in the pathogenesis. So what we are trying to do with our approach is to prevent this NOTCH3 accumulation from occurring, but others are trying to reduce this NOTCH3 aggregation and thereby hopefully preventing the negative cascade of effects which is occurring afterwards. So yeah, definitely it's a promising strategy. And regarding the preservation of NOTCH3 function, how crucial that is in the end, I think that is still an open question. We previously found evidence that there is quite some flexibility in the amount of functional NOTCH3 that you need for healthy brain vasculature, but on the other hand, there are also reports of individuals with loss of function mutations who do get some sort of small vessel disease. So I think there the final answer has not yet, the final conclusion has not yet been reached. Yeah, that's a great answer. Thank you. Very informative. There was just a comment that from Phil Jones, that's really good to know that the UK Biobank is proving useful. And I think, Bert, you covered the question on the prospect for gene therapy using CRISPR. Let's see, sorry, we have to scroll through these. How is the information about the prevalence of the disease worldwide being distributed to the medical institutions? With more understanding that it's not a rare disease, this could lead to more attention and funding.
Yeah, so I mean, our way of communicating this is predominantly via the medical literature, of course, and I think the awareness on this disorder is increasing, but still, even saying, well, 1 in 300, or in the Western population a bit lower, for many doctors, this will still be rare. I mean, we find it extremely frequent now, but for someone with all kinds of disorders, especially a general practitioner in the Netherlands, they will still maximally see only 1 or 2 CADASIL individuals in their practice, if any.
So I think this is something which also just takes time. It's a relatively, still young disorder, since it was recognized in the 90s. So this takes time, requires publications in all kinds of neurological journals to increase the awareness.
Mm-hmm. And one person asked, what about patients who meet all the criteria, but the gene testing is negative?
Sorry, could you repeat the question?
Yeah, it's what about patients who meet all the criteria of like a CADASIL phenotype of disease, but the gene testing is negative?
Yeah. So if NOTCH3 gene testing is negative and really all 24 exons have been screened, I mean, there could be a couple of things. It could be that there is something in NOTCH3 going on which you do not detect with regular sequencing. So, for example, small deletions or insertions, which you sometimes cannot detect, and you need different techniques for that. But there are also other hereditary small vessel disease that can closely mimic CADASIL. So one example would be HTRA1-AD, which is also sometimes called CADASIL type 2. So if NOTCH3 diagnostic testing is negative, what we normally do is to test a broader panel of hereditary small vessel diseases, which includes more genes than just NOTCH3.
Yeah,
there's also a question here about antibody therapy, either to clear GOM or as an agonist to the receptor. Do you have any thoughts on that question?
Yeah. Well, I mean, it's something that other groups are working on, so it's definitely not my expertise. But I mean, from theoretically speaking, or looking at the pathomechanism, this certainly makes sense. That if you could clear or reduce the aggregate formation, that might have a beneficial effect in the end on the vascular function and therefore also the phenotype. So I mean, I greatly support and encourage this. I hope that some therapeutic strategy, be it ours or be it the antibody therapy, that something in the end turns out to be really beneficial for the patients.
It's another question. First, they said, great talk, Julie, and I agree. And great research. Is there any influence of the type of amino acid that cysteines are changed to?
Yeah, this question is also asked itself a number of times. So, for example, what we compared was, well, you can, of course, have the gain of a cysteine or you have the loss of a cysteine. But so far, if we compare this, we do not see any clear differences. Not that cis gains are more severe than cis losses. And as far as we know now, also no effect of a specific amino acid. So until now, we have never found that.
That question came to us from Dr. Michael Wang. So thank you for answering that. We have another one. Is there a connection between MTHFR mutation and CADASIL? And I'm not familiar with the MTHFR mutation, so I'm not sure if you've heard of that mutation.
HTFR.
MTHFR.
MTHFR. I'm not sure. But I'm also not sure whether, if it would be there, whether I would be the person to know, because this does not directly sound familiar to me. So I would also have to dig into the literature for that one.
And the person asked because they have that mutation as well as a NOTCH3 mutation.
Oh. Well, it's really interesting. So they can, of course, always contact us if they want to discuss it further. Then we can maybe think along.
I have seen that question come from several patients that they will have the NOTCH3 mutation, but they'll have another mutation for another rare disease. Is that common or?
Yeah, I think this depends all on what the nature of the mutation is. So is it really a pathogenic mutation or is it some sort of variant of uncertain significance? So I know some DNA diagnostics labs report more DNA variation than others. Is it a gene which is associated with an autosomal dominant or X-linked disease, or is it associated with a recessive disorder, so that it's more a carriership of a certain a disease? So it's difficult to say something really general about this. I think it really depends on the specific situation, whether it's something which is relevant for their CADASIL.
Yes, I see. And this the person who had that last question, MTHFR is methylene tetrahydrofolate reductase. That would be the gene.
It does not ring a bell for me at this moment.
But good to know that you are the expert, and you would know these things. So. And there's been a couple of questions about participating in clinical studies. So the studies that you have ongoing, are those open only to patients in the EU and the Netherlands? Are they open to patients in the US? And then I will say that there are 3 clinical studies in the US that patients can join. And CureCADASIL does advertise may not be the right word, but we do get the message out there of what those studies are. You can find those on our website as well as contacting us, and we'll provide that information on how to connect for those clinical studies in the US. And one of them is just starting to recruit. That is a very large, what is called an R01 grant. Very exciting to have the NIH fund this large CADASIL study, and so we'll be sending out messages on how to sign up for that study. But going back to this question, for the studies you have ongoing, again, are they for patients that are in the US and in the EU, and how can people participate?
Yeah, our studies are really specific for Dutch CADASIL patients. This is what we are allowed to do from our ethics committee. I think the most relevant is indeed what you mentioned, Jane, that there are now also there's now funding also in the United States to set up these large studies in which patients can participate. But ours are only Dutch patients.
And I think that covers many of the questions. Some of the questions, if people feel that I skipped over them, I just felt that they were already answered. So I apologize if and just so people know, the question box is really small. So for Bert and I to read them, it's like, okay, could they make this bigger? Anyway.
Yeah, on my screen it's like half a line, and so I can't read them very well. Yeah. I didn't even see them.
Yeah, I'll show you. There is a way to copy. It's still small, but yeah, it's very, very exciting and excellent work that is coming out of your lab and Saskia's lab, and we really appreciate you sharing that information with this audience, because as one of the persons pointed out in their question, getting the message out there is just really what's going to help accelerate the research and accelerate it towards finding treatments for this disease. And we really appreciate you being a part of that work.
Well, you're welcome.
Yes.
It was a great pleasure. I really enjoyed it. So thanks again for inviting me.
Thank you very much. So I have a concluding slide here. Let me get the, oops. So again, we want to thank you and the audience. The recording of this will actually be made available, and it will be, you can reach it from our website on cureCADASIL, and we will also be sending out a survey, and we appreciate if people who have sat in on this will respond to the survey. It will give us some useful feedback. So again, thank you very much, and I think on that note we'll conclude. And Julie, again, thank you. It was great.